Well, it's a great pleasure to be here today. I certainly am not used to this being kind of a one-man show, so I will certainly do the best I can. We usually kind of come as groups, but it's a great pleasure to be here today. I've had the opportunity to both interact with physicians and patients over this past week, first in New Zealand, where I was speaking at the Heme Society of Australia and New Zealand, and we similarly got together with a group of MPN patients in New Zealand and learned about some of their challenges, as well as over these past few days here, both with consultants around Australia yesterday in Melbourne, and then you find folks here today in Sydney. So they had told me that it's never warm in Sydney, so as I saw today that it'll be 40, but it's a beautiful city, so it's really a delight to be here. But before perhaps we begin, it might be helpful for me, one, perhaps a show of hands, who here has an MPN? Great. And then who are here kind of in support of individuals who have MPNs? Fantastic. Now for all of you, is this your first, raise your hand if this is your first kind of similar sort of MPN patient meeting? Okay, so the majority. Well, good. Well, these sort of meetings actually started a long back, over 20 years ago. Many things in MPNs in the world of blood disease as well as cancers have sometimes really started with MPNs. And in part, that's really been due to the innovation, I think, of many MPN patients that have been very engaged and trying to better act as a community and as a resource for other MPN patients. And it's clear when you have a disease like this that you don't hear about on the news, there's not magazine stories about it. When you have a disease that's not common, there is really an education gap. And you get information from your hematologists, but again, those visits are time constrained. There's a lot of information. It's complex. There's a lot of things to digest. So the need for educational events to complement that, as well as support from foundations like the Leukaemia Foundation and other educational forums, are incredibly helpful in that, and I find trying to better understand your disease, where you fit within that realm, if you're on a therapy, why are you on the therapy, what are the goals of that therapy, how do we evaluate whether that therapy is helpful, what might the future hold or not hold. All of those things are incredibly important. So it was well over 20 years ago, one of my patients who was very active in trying to bring together groups of MPN patients, Joyce Niblack, really first brought together the concept of bringing together people who specialized in the disease, whether it was in the lab, whether it was in the clinic, as well as with patients. Now for many physicians, this was a very different experience. For many of them, they found it a little frightening. Boy, I never stood in front of a whole room full of patients. That could be a little intimidating. But for most have found really over time, one, as we'll share with you, it's led to a lot of advances in that, I find MPN patients bring a lot of their own experiences, innovation, experiences from a whole range of other fields or businesses that sometimes can lead to advances by asking questions. And it's certainly incredibly rewarding for us as investigators, and that these are not just theoretical diseases that just exist in some vacuum. These are people that have these difficulties, and how can we really try to make a difference? So I find these to be very rewarding events. Now, for those new at these events as well, there's just a couple ground rules, but a key one is that certainly it's my place to try to give information in the best way that I can. What it's not my role is in any way to try to second guess, what your consultant hematologists have recommended for you as an individual. Not fair to you, not fair to them, certainly not fair to myself either. So I try to answer things in a general term. You can ask questions, but I will answer them in a general term in terms of what goes into a decision, but certainly won't be recommending a change of therapy or a dose change or things of that nature. That clearly would not be appropriate. So the presentation is regarding a theme of the efforts that my team has worked on, and the QA clearly can be whatever you'd really like to ask. But my group overall has been very interested in trying to better quantify the difficulties an MPN can cause for patients, and how do we better overcome those. Fundamentally, when you have an MPN, we need an accurate diagnosis, we need to assess how it is affecting an individual, and then we need to come up with a plan. And that plan might include watching, it might include how we monitor the disease, it includes should we begin medicines, and medicines themselves fall into different categories, or do we need to use very aggressive treatments such as bone marrow transplant. Now, MPNs are a very heterogeneous group of diseases, as are individuals that are afflicted. I know in this room itself, there's individuals that have even been diagnosed as early as the age of 1 that have an MPN, and that's clearly an outlier. But you could go from 1 to really any age to being affected with an MPN. So again, it can affect us at any range of life. And there's individuals that truly range from, I would not know I had an MPN had it not been found incidentally at the time of a blood count. You know, when I worked at Mayo Clinic, and now I'm director of the Cancer Center at the University of Texas. But at Mayo Clinic, 60,000 employees, many people getting general physicals. So some rate of individuals found to have elevated platelet count or elevated red cell count, who again were found to have an MPN that had 0 symptoms, 0 problems. To the other end of the spectrum, people who were very ill and trying to identify why they were ill led to the finding of MPN. So again, a very mixed group of diseases. Now, when one has an MPN, one might put you in one of 3 different groups. And people look at each of the groups almost with great focus. Essential thrombocythemia, or too many platelets, polycythemia vera, too many red blood cells, and or myelofibrosis. Now, although we have different kind of ways we classify people within each of these 3 groups, there is a lot of overlap that exists between them, and there's some individuals that don't perfectly fall into one bucket or another. The way I really address an individual patient with me with an MPN is a little less around that label. That label sometimes is helpful, but not always. But really, what has the MPN meant for that individual? One, there's a risk of what we call vascular events. We use that term because it might be in either blood clots or bleeding. Now, people are sometimes surprised. Well, blood clots make sense. You have an increase in the blood counts. The cells get clogged in the blood vessels. So that makes sense. But why do people have bleeding? Well, when we form blood clots in the body, we need both cells as well as other proteins that gather those cells together to hold them together. These are the clotting factors, von Willebrand factors, and others. When our bone marrow has an MPN that's making too many cells, we make too many cells, but the other part of the body that makes those clotting factors does not make any more clotting factors to compensate. So you end up having an imbalance between them that ironically favors bleeding because you don't have enough of one to balance against the other. So this is a key part. And actually, as we end up discussing over time, most of the treatments in ET and PV have focused almost exclusively on this. Aspirin, hydroxyurea, phlebotomy, anagrelide, etc. It's almost all been really aimed at decreasing the rate of vascular events. They are diseases that clearly can lead to a drop in the blood counts. Although they tend to be high to begin with, they certainly can lead to a drop, particularly in myelofibrosis. but in PV or ET, either as medication-related side effects, progression, what have you. They are diseases that can lead to enlargement of the spleen. Now, the spleen is normally the size of our fist. It lives under the rib cage. It is a filter for the blood. It's normally 100 to 300 grams. But in MPNs, they can be quite enlarged. By the time we can feel the spleen, it's probably twice its normal size. By the time it's well down into the abdomen, it might be up to 8 or 10 times its normal size. MPNs clearly can cause symptoms, and we'll get into this to a greater depth. And the symptoms fall into different groups. There are symptoms related to the blood counts being high because the blood isn't flowing well. There are symptoms related perhaps to elevation of proteins in the blood that lead to inflammation and cause night sweats or things of this nature. There are symptoms related to that big spleen. You can imagine if a spleen is large enough, it can cause discomfort, it can cause pain. And there are diseases that can progress. And for most patients with an MPN, this is actually the thing that we are concerned with the most. For most people with an MPN, if they never progress from the time that they were diagnosed, they would live out the rest of their lives as they would have otherwise. They might have symptoms, they might have difficulties, but it is progression that is the villain, and that can make these diseases more life-threatening. And then finally, the rest of your health. We are never just an illness. You're not an MPN. That's just one aspect of your health. And if that's the only thing that is impacting your health, that might be very different than if you have multiple other problems. So if you've had heart disease or lung disease or liver disease, an MPN might be a very unwelcome addition. Or if you have none of those other problems, you might actually tolerate an MPN much better if you don't have those other medical problems. Now, MPNs can affect us in a variety of ways. And in this talk, you hear some things that you don't normally hear because our group has had an interest in shining a light kind of under every rock from the perspective of what really is that overall burden. And one of those clearly is around employment. That individuals, because they choose to retire early because of uncertainty or because of symptoms or because of complications, might have issues with employment. So this was a US-based survey, but we saw that from a third to a half of patients with MPNs had some impact on employment. Typically that was in part self-selected, but that could be a reduction in work hours. It could be a range of things. I've had physicians, as someone who specializes in these diseases, I have many physicians, they have an MPN, they come to see me. And they'll tell me, well, before I had an MPN, I didn't think that MPNs were a very big deal. But after I had an MPN, I realized that even if my blood counts didn't look that abnormal, I had fatigue, I couldn't see as many patients in clinic, I was better off working half days. If I needed a phlebotomy, I had difficulties concentrating. If I was reading a journal article, I could only make it part of the way through the journal article. So it made it much more real for them. I used to think my patients were crazy when they told me they could tell that their platelets were over 1 million, until mine were over 1 million, and I had difficulties concentrating on reading. So these things are very real. They have a real anchor in biology, and again, they're one important aspect of the disease. Now, we're very interested in terms of also understanding the perspectives of both patients and physicians. As I tell you, how historically the treatment of MPNs has evolved for physicians is important to understand in that it helps to explain a few things that you may have found along the way. One in particular is that all teaching regarding treatment of MPNs in the past has largely only focused on avoiding blood clots and bleeding. So most consultant hematologists have only focused on blood counts. And this isn't wrong, this is just how they were taught, that's what was in the books. You focus on the counts, you only focus on the counts. I don't even need to see the patient because all I need to do is look at their blood counts and know whether they're doing well or not. And if I control the blood clots, then they have blood counts and they have less blood clots and bleeding. So that's how all the teaching had been done in the past. So not surprisingly, physicians far prioritize the prevention of vascular events as their key goal. With patients, nobody wants to have a blood clot, but they clearly have a range of important goals, of which the biggest discrepancy between patients and physicians is the issue of progression. I don't want to progress. For physicians, it's not wrong, but their perspective, how physicians think, is I don't know if I have a medicine that can avoid progression, so progression's not one of my things on my radar. It's not my target because I don't know if I have a therapy to avoid progression. This was similarly true in patients with polycythemia vera, as well as with myelofibrosis. Interestingly, and perhaps due to some of the efforts of my group, physicians now truly are much more attuned to the issue of symptoms, but clearly the issue of avoiding progression, a strong priority for patients. We also repeated this study internationally just to see, well, was this a US-based phenomenon? And it was not. So this was a similar study led by my colleague, Dr. Claire Harrison. Now, what about the symptoms? Again, it can really range from nothing to a whole range of difficulties. Now, with most folks, as we really dig in, it rarely tends to be nothing. There are times, because they're very chronic illnesses, there may have been things that you just became accustomed to, and over time, maybe they don't bother you very much. Maybe they're so baked into how you baseline have your expectations of how you feel, you don't notice it until sometimes we treat it and you're like, wow, I didn't realize I felt poorly until I felt better. You know, and that can happen as well in the arc of a long chronic illness. Now, it was one of these issues, it was back in 2004 that Joyce Niblack, we were at one of these patient conferences. We had held a couple of them already. And she was a strong advocate, and she was an incredibly bright woman. She was a chemist. She was a patent attorney. And she had a strong desire for us to better quantify this issue of symptoms. Because again, many patients were finding, you know, I go in to see my consultant hematologist, and, you know, I look well compared to the patient in the clinic, and, you know, there doesn't seem to be a lot of concern regarding the symptoms that I'm feeling. And as I try to educate, you know, our colleagues in hematology, you know, in the US and around the world, you know, trying to frame MPNs is important as well. It is true that the individual that they saw prior to the patient with an MPN might have acute leukemia and be incredibly ill, or just had a bone marrow transplant. And the person afterward might have life-threatening lymphoma. Those are different diseases. And it is true that you may not be as sick as those individuals. But in the context of your care, that doesn't really matter. I mean, it's not a contest. You know, it's not a race. They are just different things. The expectations are different. But people being, you know, we are who we are. Again, trying to look at each patient just in isolation is crucial, because the fact that other people can be more ill really has no relevance in the context of having the disease that you have. So she was very interested for us to really try to assess symptoms, try to see what that is compared to the general population, and try to see what we could learn from that. So we worked to try to develop a series of questionnaires that could help us to study this. I created it first in myelofibrosis, a series of questions, and when one goes through this process, the questions have to go through a series of steps to see, well, do people understand the question? If they answered it twice, will they answer it both times the same? So a variety of things so that a questionnaire is what we say is valid. Is it measuring what it's supposed to measure? And if it changes, does that actually correlate with the fact that something actually changed? So we created one in myelofibrosis that included constitutional symptoms, spleen-related symptoms, fatigue, and quality of life, and then added additional symptoms regarding blood flow-related symptoms and mood-related symptoms, and created what's called the myeloproliferative neoplasm symptom assessment form. We now have this. I have to update the slide, but we have it in 19 languages that have been tested in 48 different countries and have data in about 6,000 patients. And we did this as purely a collaborative effort between people engaged caring for MPN patients around the world. And what we learned is that MPN patients are very similar. We found that the ranking of symptoms by disease was almost the same, independent of culture and geography around the world. So as I was able to compare, some of you may have completed these. Sydney-siders versus those in Melbourne versus people in Uruguay or Pakistan or Madagascar or Texas, that the experience was remarkably similar. Now this is an example. This is just the 10-item form. People could fill this out. We're working on an app in the English language with a UK group to have it be here as a resource for patients in Australia as well. With the advantage of many of the things that we do are easily translatable here for use for patients in Australia, New Zealand, and other English-speaking countries easily, and then as we work through the validations for other cultures. But this is an example of the score, both in English and Arabic, although in Arabic, of course, we go from right to left in terms of the scoring system. It allows us to track really differences. So as we look at scores, it's all meant as seeing how one individual changes, as opposed to comparing how two individuals change. So for example, my baseline of 4 for fatigue, might be somebody else's 7. That's probably less relevant than if my 4 goes to a 2, that might be very similar to that individual's 7 going to a 5 or to a 4. So in all of these things, they're all kind of internal comparisons where these things are valid. And it's not only limited, of course, to MPNs. These sorts of ways of trying to quantify patient input in terms of how they're feeling in a concise way is a very important part of how medicine is evolving. Whether we're evaluating whether you have difficulties with pain or a symptom, and whether it's MPNs or another disease. Now what we find with these efforts is, one, the symptoms are common. This on the left are individuals that have it present at any degree. So this is data in over 2,000 patients. And in green, the lines at the top show that they are the most common in myelofibrosis. There's some of these symptoms that for me suggest progression versus present across the board. So fatigue is very common, whereas things such as fever and weight loss I find are much more likely to be associated with progressive disease. Itching is very common across the board, the most common in P. vera. Here is intensity, and these are medians, meaning if you line them all up, who is in the middle. It's important as well as people fill out these sort of forms. Again, most individuals, the psychology behind these is that they're not filling out, mine is a 10 out of 10, it's a 4, it's a 6, it's an 8, but there's a psychology in terms of how we address these sorts of things, with the assumption that we have no kind of predetermined interest in terms of what the score shows. Now, some in our field have pushed back and said, well, Ruben, I've heard you talk on these symptoms with MPN patients, but many of them sound like the things that I have. I'm driving my kids to ballet, and then I've got to go to work, and then I got to do this. So, I'm tired, I'm fatigued. Are these symptoms really different than the general population? So our colleagues in Ireland did a study we collaborated on, which was with age-matched controls. They had, for each individual MPN patient, they had a similar person of age in the general population that they were able to go out and measure their symptoms. Perhaps a little different than the folks last night who were doing the revelry for St. Patrick's Day. I came in here to Sydney not realizing that there was the Irish bar on the corner. So the pandemonium that was here at 10 p.m. last night really can't be adequately expressed. It was almost kind of a river of green beer and drunken revelers, but it was fun. But comparison with this group, with let's say the non-pub going Dubliners, clearly showed that for each individual symptom in a statistical fashion, clearly different than the general population. Now, there's a lot of times that symptoms and quality of life get used as an interchangeable term. And let me explain some of the importance of the differences between these two. Quality of life is a very global concept. It takes everything in your entire life and you put it together. As an American, just Donald Trump just lowers my quality of life just in this kind of gnawing headache, sort of, almost anxiety-inducing way. Clearly, if we have some terrible life event, we might have a terrible quality of life. We lose a parent, but that's got nothing to do with our health. Health-related quality of life is looking at all issues related to your health and how that impacts your quality of life. So it clearly does include symptoms. And if a symptom is bad enough, it can be overwhelming. So let's say, for example, itching. For some, if you really have uncontrolled itching, it can really be overwhelming. It's a bit like if you have hiccups that won't stop. Until that's gone, it's hard to get past that. There's nothing threatening about hiccups, but if you ever have a stress like that is all-consuming for that period of time. So symptom clearly can be overwhelming. But it clearly can include medication-related toxicities. So if you're on a medicine and it makes you feel lousy, that is a big factor. If you've had prior complications, and that's frequently not discussed, if you had a blood clot and it causes complications, that too can be a factor. There are the stressors of having the illness. Perhaps it's financial, perhaps it's emotional. For some people could say, well, it might progress, I could put it out of the back of my head, I'm not going to worry about it. For others, it could be overwhelming. I don't know what 20 years from now is going to look like, and that is going to really, I just can't get past that mentally. There can be intrapersonal. One of the challenges I think I've learned from chatting with MPN patients over the years, which I think is logical and not unique to MPN patients, is a special challenge of having a disease that isn't common. Because when you have a disease that's common and you tell someone, they have an instant frame of reference. I have breast cancer. Terrible thing to say, but people immediately related to, well, my mom had breast cancer, but she did okay, and my sister had breast cancer, and I saw 10 stories on the news on breast cancer, so they have all these ways of framing it. You tell them you have myelofibrosis, and they go, Gesundheit. What is that? So then there's this extra layer of, one, I need to reflect and share with you what I have, and either one, make it seem like it's no big deal, because I don't want to seem like I'm complaining, or two, they think that you're going to die tomorrow, and then start acting all weird around you because you've got this disease. So that part is not insignificant. And for the folks from the Leukemia Foundation, it's not unique. There's a whole bunch of diseases you've never heard of, amyloidosis, mantle cell lymphoma, I don't know, all these things that people have just no concept, Waldenstrom's macroglobulinemia. So sometimes people say, well, I don't even want to tell anybody. I've got it because it's just too much hassle. It's clearly not an elevator conversation. Oh, how are you doing? Oh, I have myelofibrosis. Oh, well, I better get going. Your comorbidities clearly can be an issue. And then the hassle of medical care. So I advise the Food and Drug Administration on drug approvals, both in MPNs and have been on some additional advisory sort of groups. And this is one where I think slowly the FDA, the EMA, and others are starting to wrap their heads around this. So in the past, they used to say, well, you know what, blood transfusions, no big deal. Need a blood transfusion? We give you blood. What's the big deal? I'm like, aha. I'm like, clearly not you. Because if my patient needs blood and it's 4 p.m., and the unit only has the capacity at a chair at 8 p.m. to give them 1 unit. So now they're waiting around for 4 hours. They get the 1 unit. They get 20 milligrams of Lasix so that they're not fluid overloaded. They end up peeing all night, and then they have to come into the unit tomorrow for the 2nd unit of blood, and that again takes another 2 to 4 hours. So that is a huge hassle. It interrupted sleep. It just disrupted whatever they had planned to occur during that time. So the hassle of medical care is clearly an important factor. Now, people have asked, well, you could quantify symptoms. How symptomatic do you have to be on a therapy? I had this conversation with 50 hematologists yesterday in Melbourne, here in Australia. For the use of JAK inhibitors in patients with myelofibrosis, they have to be, if they're intermediate 1, they have to have the disease and they have to have difficult symptoms. So how difficult do symptoms have to be to mandate a treatment? One, that question really starts with you. Are the symptoms difficult enough that taking a treatment is worthwhile? Whether that be in terms of side effects, whether that be in terms of expense, whether it be in whatever that is. From the physician side as well, do we view that that is problematic enough or threatening enough that it makes sense based on the safety, benefit, etc. of the medicine? Not only to start it, but then as we look at it after 1 month or 3 months or 6 months, is it beneficial enough to continue the medicine? What we can say from a mathematical perspective is that individual symptoms that are a 5 out of 10 or more, or aggregate scores of 20 out of 100 or more, are in the fairly severe group, and it's at least a discussion. I sometimes find as well that one really bad symptom can be a bigger problem, more in need of therapy than several low-grade symptoms. Now, everyone's wired a little differently, but the disruptive capability of one really bad symptom tends to be less than, so 5 1s tends to be much less problematic than 1 5. This is also true in patients with PV and ET, and what we find is as people have more symptoms, they correlate with the biology. Not 1-to-1, but they have higher counts, they have more spleen, they have more other biological evidence of the disease being problematic. Now, this slide is a little too small to read here, and certainly I'll let the folks from the Leukemia Foundation and others know that you're certainly welcome to have a copy of these for you to look at in detail. This is a comparison of the symptoms and risk scores in each of the diseases, and we won't get into them to a great degree because I think that sometimes it's more distressing than helpful. There are risk scores that each of the diseases can have that can either give some prediction in terms of the likelihood of developing a blood clot or how life-threatening the disease might be. That the issue of risk and the issue of symptoms have a relationship but are not the same. Meaning there are individuals that might never have a blood clot but can have some symptoms, or have had blood clots but have not had a lot of symptoms other than that. So the two things are not necessarily interchangeable. Now, we've had a great deal of interest trying to understand the spectrum of the symptoms and how they correlate, or what we call is heterogeneity. And using some mathematical tools, this is data that represents the symptom scores of over 2,000 patients in a graphical way. with each line representing an individual patient, very thin, with each symptom being blue absent to red, the worst it can be, to anywhere in between. So you're able to absorb a tremendous amount of information in a graphical way. And what it shows is there are clusters within each disease of difficult symptoms, and there are some symptoms that are linked together. So there's some that you could just pull right across. So right here, you see this line, that's fatigue. Fatigue, fatigue. You could see others that we'll end up discussing in a moment that you'll hear in no other talk, issues of sexuality. You could see that as a bright red line across each of these. So we've studied these and learned some lessons that we want to share with you. One, we've learned that time is a factor. With an MPN, the length of time you have the disease is a factor. It's a factor in terms of risk of the disease changing. It is a factor in terms of symptoms potentially accumulating. There is the impact of gender. And again, we had as really a question from our patients saying, there's multiple reasons, whether it be differences in hormone levels, whether it be anatomy, etc., that MPNs might affect patients who are women versus men in a slightly different way. There have been different cutoffs for phlebotomy goals, on and on. So we were able to find, and this is culturally independent, higher levels of fatigue, abdominal symptoms, microvascular symptoms for women over men. And this was true whether I was looking at women in Shanghai, versus women in Australia. The issue of insomnia, much more prevalent than we had anticipated. One, insomnia in the general population is a big problem. In MPN patients, it's worse. Now, some of these things are really logical. Insomnia, and as we talk about intimacy, they are a little bit of aggregate constructs, meaning if you're having night sweats, you're uncomfortable finding a good position to sleep, you're having itching, you're having restless legs, you're clearly going to have difficulties sleeping. But issues of insomnia are a big issue. And as we look at some of the complementary techniques that we've been looking at trying to tackle, some of them have as some of their benefits in terms of sleep. You find as well, if people are imbalanced in terms of their counts and their need for a therapy and the disease is being treated, the improvement of sleep is a good surrogate for me of aspects of quality of life. One that is a particularly important aggregate construct, meaning this is really the canary in the coal mine, is the issue of intimacy. Because if you don't feel well, this is one of the things that usually kind of gets dropped from somebody's life in the quickest fashion. I've had patients tell me, I'm having night sweats, I'm having this, I'm having that. The last thing I'm thinking about, is issues of intimacy. So this is an important one. By patients' own direct accounting, it clearly is one of the most difficult things that people relate across 40-something different countries. The most intense, the closer one gets to the Mediterranean, a little less in Scandinavia. Australia is somewhere in the middle, but again, a very, very prominent difficulty. By the flip side, I do see as well that if patients say, and we discuss these things, that if this part of what is an important part of their own lives, of their own self-identity, if that corrects, that is a tremendous statement in terms of, are things really in a much better place for them? Now, what about link with biology? So there's always much discussion as you think about things like this. How much of it is disease? How much of it is the stress of having the disease, or how one is cognitively approaching the disease? So are there really mood disorders over the anxiety? And how much is very specifically driven to a big spleen, inflammation, increase in markers, etc. So again, another very active, very bright man, Zen Senyak, who has been a passionate advocate for MPN patients, and he was a journalist and has really taken those skills as really working to educate folks. He pushed and he said, Ruben, I interact with a lot of patients, and I'm concerned that some of them might be depressed. You guys are the doctors, but if you have depression and that's not treated, that can't be a good thing. We had found in other diseases that I had worked with colleagues who study other blood diseases, again found that these are not insignificant issues. This issue of, I don't know what 5 years from now is going to hold, and some people can tolerate that and put that in their brain somewhere and not have that be a barrier. And for other people, while that is out there, they really can't concentrate on anything else because they're so worried about what 5 years from now is going to hold. So we did a study that looked at a variety of different questionnaires that helped to get at issues of mood to try to quantify this. Well, how big an issue is this? So we looked at 1,800 patients and found that there were much higher rates than the general population of depression, anxiety, stress, and grief in patients with MPNs. Now, clearly, this is not everyone. It's not to say, boy, I didn't think I was depressed before I came to the talk. Now I'm really depressed. No, that's not what it means at all. But what it does mean is that it can be a real thing. And what I'm telling physicians is they need to really be mindful of this. Because again, if I have a patient who comes to see me and what they really are have issues of anxiety or depression or grief, all the adjustment of their pegylated interferon on the world isn't going to fix that. So need to be very mindful of those feelings and how we try to deal with them, as well as sometimes broaden the team, again, to bring in whether it's psychologists or psychiatrists or others to help if that is the factor. Just like any reactive state, people can have a pathological reaction. We all can have a terrible event where we lose a parent. Some of us, we overcome that. It's difficult. It's not to say that's ever a good thing. But other people can really be thrown into a very severe depression that can be very harmful. So again, separating the two is important. It's also true that if you have these things and they're untreated, the symptoms are going to be a lot worse. So for mine, I'm particularly mindful, we have to be mindful that as we're adjusting things with MPN-related therapy, we're really adjusting things for the MPN and not really trying to deal with a different set of issues. So mood is clearly a factor, but it's also the issue of inflammation. Now, this kind of Rorschach block here of represents what are called cytokines, which are proteins involved with inflammation in patients with myelofibrosis. And red means that they're higher than normal, and green means that they're normal. So you could see in this group of folks, these proteins were all increased. Now, this increase in these proteins that are increased with inflammation in MPNs are important because some of them are associated with enlargement of the spleen, some of them with symptoms or disease progression, or even the disease being more life-threatening. So these are real things. We can measure them. They have direct biological effects. And they have an impact on inflammation. They might impact risk of blood clots. They might have a relationship to why people progress to myelofibrosis from ET or PV. They may even have a relationship, why do people progress from MF to acute leukemia? Indeed, as we ask, why do people progress from either ET or PV or early MF to overt MF? They may not progress. So again, for many individuals, progression is not an automatic. But if progression occurs, it can progress to either myelofibrosis or to acute leukemia. There are some individuals who sadly can pass away from MF because they were sick enough to begin with. They didn't have to progress. It was problematic enough from the beginning. Now, in the world of blood diseases and cancers, we typically have felt that this has been largely driven primarily from increase in mutations, meaning additional genetic changes. What we're learning is that the microenvironment and inflammation may play a role. Now, how do we think about symptoms and how we treat the disease? So one, I could say that the MPNs have been a leader in terms of trying to incorporate the voice of patients in terms of new drugs development and their approval. The FDA has actually used MPNs as a model to advise the rest of drug development in cancer-related drugs on how to do this. And given the rarity of MPNs compared to other diseases, it's something that we're pleased was the case. We have evolved that absolutely every single large trial for MPNs includes mandatory assessment of symptoms serially tracked over time. And that really has been a tremendous advance from it was only about the blood counts, it was only about the spleen. Now, I'm going to show you the US-based guidelines that, knowing the Australian guidelines, are not too dissimilar, but I will show you where we incorporated symptoms into this, what is the standard US treatment for MPNs. And I had the pleasure of leading these efforts along with colleagues from around the US, including many well-known MPN experts such as Serge Verstovchek and others. So when it comes to diseases like myelofibrosis, we have at every step along the way an assessment of symptoms, not by itself, but in addition to all of the other factors we discussed. Well, what's the spleen? What's their age? What are the blood counts doing? Have they had a prior blood clot? What are the chromosomes? What are the genetic tests? But that all of these things really get factored together. Now, in low-risk myelofibrosis, we think that if you're symptomatic enough, we may choose treatment. Now, which treatment, again, ends up being a discussion between the consultant hematologist and the patient. Are we trying to reduce splenomegaly and symptoms? Are we trying to impact progression? Is it too early for us to be concerned with either? With ET, we similarly include along the way, and these are not user-friendly, so I am not going to go in them in detail because they're complex algorithms that largely try to frame for consultant hematologists in the US, although they're used in other countries by extrapolation. What are the parameters in which, how do we track a disease? And then what are the things that factor into the decision regarding either starting a therapy or changing a therapy? Overall, thematically, what I try to educate consultant hematologists around is one, if there are some key goals in MPNs are one, that therapies tend to get started in too delayed a fashion. So one, are they started early enough? And then two, if you're on a therapy, is it really achieving the goal that we had? And not sticking with a therapy indefinitely if it isn't really helping. Or whether you're using it, but the side effects really are unacceptable. There are ones for low risk, there are ones for intermediate risk, and in each of these along the way, it involves not only how do we start with a therapy, which in this case is starting with aspirin and monitoring, but then how do we track the disease over time? Are there changes in symptoms? Are there new events? Did we control the counts? Is the medicine well tolerated? So it's in these fashion that we really try to guide the art and science of medicine. What I share for folks is that these guidelines, and there are similar guidelines in Australia or in the UK, etc. Guidelines frame the science of medicine. What is within the realm of reasonable for managing a disease, and what are the things that help to inform the decisions made within there? The art of medicine is making the decisions within those parameters. So if I wanted to use a drug for breast cancer in patients with intermediate risk ET, I have no basis for doing so. And that clearly would be both inappropriate, and I would even be liable for doing such a thing, because it makes no sense. Whereas within here, again, that is where the art of medicine occurs, when to start, when to change, how to factor these things. That's where the experience and the training and all of these things come into play. Similarly with high-risk ET, and then similarly with polycythemia vera. Now, where else do we go in the future? So as I was chatting a little bit with the Leukemia Foundation folks earlier today, see that in my group, there are several groups of individuals working on MPNs, and more than have ever been in the past. There's individuals that are deeply in the lab working with mice and with cells, trying to understand the genetics.
Sorry, continue.
There you go. It's the way to be certain I don't run long. So one, looking at the biology of the disease. Two, looking at other medicines or transplant to improve the diseases, and that's an area where I and others are deeply involved. But then third, what else can we do? And my group has been very interested in this area. We've spent all these years understanding the difficulty in symptoms. We understand that medicines can improve them, but typically don't take them away. So working with many collaborators, we've asked the question, well, what else can we do? Because I may not be able to make you feel as well as I can by solely just prescribing other medicines. So one area we've had an area is the issue of yoga. And yoga, one, I do this in collaboration. People look at me and go, this guy does not know yoga. They would be wrong. I have gone to the intro to yoga with my wife and daughter. My daughter's 19. I told her that she was not allowed to photograph any aspect of the yoga. She did have several Instagram posts, but at least there was no pictures of her father in this. But yoga is a particularly interesting part, clearly done in collaboration with people who are experts, that brings together both an aspect of meditation as well as an aspect of physical activity. And it's been found to be very helpful, but primarily been studied in areas like breast cancer and others. So we've done 2 studies, the most recent of which was trying to show can people do it? Can we deliver it to their homes? So we worked with an online yoga provider called Udaya. We taught them over 3 days everything there was to know about MPN so that they could design a yoga program specific for MPN patients, modifications for splenomegaly, etc. And then develop this 12-week study, randomized into 2 groups. One that got the yoga to start with, the other was on a wait list, and then went to yoga for the second set of 12 weeks. We were able to measure symptoms, quality of life, participation. We could even track blood tests remotely, including markers of inflammation. With this, we had over 260 patients who signed up for this in a fairly short order. We were able to track their actual participation. There are tools where you can actually check how many minutes they're actually watching on a daily basis. And we found significant, one, we could find that it was feasible. People could do it. It was safe. They found that they could follow the yoga. It had a significant measurement impact on depression, sleep, and several other aspects. We could obtain remote blood counts and blood values and measured improvement in inflammatory markers. So now we are planning a large phase 3 randomized study on this basis. And this showing differences in these different various components. The next is this issue of a cognitive therapy. And again, with each of these, working with different groups. This is, again, with psychologists and psychiatrists, and brainstorming around this. And this therapy that is called acceptance and commitment therapy, it's been used in chronic conditions. This is a series of 8 modules that are designed to help people who have something that is unfixable, whatever that is, and how do they wrap their head around that to be able to get past that mentally, or at least be able to frame it most appropriately in their minds. And this has been quite helpful in chronic pain, fibromyalgia, and chronic fatigue, as well as a range of different benefits in individuals with different cancer-type conditions. So that we have completed accrual of a face-to-face ACT study with my colleagues at Mayo Clinic, and are developing online modules for the next set of testing, both in English and in Spanish. Finally, one of my strong collaborators who's joining me in Texas, Robin Scherber, has a great interest in anti-inflammatory diets. Again, inflammation is clearly increased. Certainly in terms of ingestion, by far, by volume, the greatest thing we do every day, of course, is eat. And there are many different sets of information to suggest that diet might be able to impact symptoms and inflammation. Now, there's not one anti-inflammatory diet, there's hundreds, and there's many questions. So we've started our efforts with trying to best understand the landscape. What are people eating? Is this an opportunity? Are people interested? And then the next, trying to ask question, well, one, if we try a diet, what diet? How does one really educate people around that? How does one really track that? How does one help to support that? We have collaborators that have developed apps for diet-specific interventions with grocery stores in the US that literally will then be able to give you a shopping list as well as recommended dishes. One has to factor in how many anti-inflammatory meals per week, because the challenges, all of these sorts of things are, yeah, I could do this when I'm at home, but Friday I've got dinner at my mother's or what have you. So there's all these different practical factors. So these are feasibility studies we're trying to see. One, can we do it? But then two, can we show that there is a difference in inflammation, and or is there a difference in terms of symptoms? So I'd say that the burden of these diseases is quite mixed. And being mindful of the spread of the burdens is important as we really try to come up with an appropriate treatment plan for you. Symptoms are real. Not everyone here may have them, of course. Now down to 7%. Now we're getting serious here. And clearly can be linked with the biology of the disease. These are not alone. And for those from the Leukemia Foundation, they clearly are not only in patients with MPNs. They just haven't been studied to a great degree. There are diseases where they're even worse, and others where it has not been fully investigated. The serial assessment of your input in terms of your care, not only in terms of symptoms, but other things, is incredibly important in terms of how we deliver care for a long-term chronic illness. And I think there's much advancement in the science of that. Structured communication between you and your consultant hematologist, which I think is key and welcome. And finally, we clearly are looking at a range of non-pharmacologic interventions. Now, at the moment, I can't say that we're done with any of them yet. Our eventual goal is to say that we will have a range of things that have been scientifically validated that can be a resource for people to be able to pull up like a toolkit, and choose them with their consultant hematologist to say which of these things might be helpful and how they are delivered. So they're not ready for prime time, but clearly that is our goal. And with that, have our MPN Quality of Life Study Group that includes our investigators in Texas, my former colleagues at Mayo Clinic, Arizona State University, and University of California at Irvine. And with that, fortunately, we still had 6% left on the laptop, so we're good. But with that, open it up to questions, including not only limited to the presentation, but really questions on